Ladies and gentlemen, please welcome to stage Chair of NHS Confederation, Stephen Dorrell.
So, ladies and gentlemen, I welcome you to the final session of this conference. I hope you feel that today, like yesterday, was upbeat, informative, and gave us all food for thought. I'm certain this last session will reward you for having decided to stay the course, because we have some interesting opportunities to look at ourselves through the eyes of others. What I'm proposing to do is to ask Vaughan Gething, the Health Secretary for Wales, to speak first, and then to have a brief conversation with him and invite you to put some questions to him. Then I'm going to invite representatives from the Local Government Association and Ipsos Mori to come and talk about their perception of localism seen from an English as opposed to a Welsh perspective. And then finally, we're going to have a closing address from Sir Bruce Keogh. So let me begin then with Vaughan Gething. We've had numerous references over the last couple of days to the importance of ensuring that our health and care system in England is open to ideas from outside England. And very often, that is heard to be a suggestion that we should look for ideas in North America, in Australasia, in continental Europe. But too often, we look over actually different experience of health and care that is available at home within the United Kingdom. And so, not just as an Englishman welcoming a Welshman, but also as a former Tory politician welcoming a Labour politician with health responsibility in Wales, it gives me very, very great pleasure to ask Vaughan Gething, who is the Health Secretary for Wales, pursuing a different health policy in Wales from that which we pursue in England, to come and talk to us about his experience of a different perspective here at home within the United Kingdom. Ladies and gentlemen, please welcome Vaughan Gething.
Thank you, Stephen, and I'm very grateful for this opportunity to address Confed17 conference. The last time I was here for the Royal College of Nursing conference in Liverpool. I do enjoy coming here. As we often say in Wales, Liverpool is the capital of North Wales. And my formal and full title, as you see, is the Welsh Cabinet Secretary for Health, Wellbeing and Sport. I have the longest title in the Welsh Government. That therefore means I'm the most important member of the government. But sadly, though, in terms of community sport, it doesn't mean that I get the tickets. You need to see my friend Ken Skate if that's it. But actually, community sport has been deliberately brought into this portfolio to think about our challenges in getting people active and recognising the impact that sport has on general health and well-being. But the themes of this conference have been the localism agenda, and in particular, the increasing devolution of health and care responsibilities in England. Of course, it's nearly 20 years since responsibility for health and social care in Wales was devolved to the National Assembly for Wales. And that devolution of health and social care to Wales, Scotland and Northern Ireland at the end of the 90s, though, was a very different process to what's now taking place in England. We have, though, in Wales, learnt some important things on our journey that may be useful to colleagues from England and further afield. But it is important to recognise that the path of asymmetric devolution in England does have the potential to lead to greater divergence in patient outcomes than we have previously experienced across the UK. As the NHS heads for our 70th anniversary next year, that is something for all of us to be proud of, irrespective of the structure and policy differences that arise across the UK. But we have long argued that greater devolution should encourage us to increase our connections across geographies and service systems, and something which will become increasingly important against that developing picture. We think we need to look outwards and not simply inwards, because we can learn from and grow with each other. But devolution in Wales has allowed us to make bold choices about the way we structure, plan, and manage our health and social care system. It's enabled us to work much more closely with other public services beyond simply the NHS and social care, in a way that allows us to build relationships and trust across sectors and organisations in a distinctly Welsh context. As the eminently quotable Nye Bevan once said, socialism is the language of priorities. In a modern context, where devolution is a growing feature of the United Kingdom, devolution is the language of choices. And by that I mean a belief that choices made locally can be more in tune with and more appropriate to local circumstances if we connect people more closely with decisions that affect them and decisions that they themselves will take. None of this to say, of course, is that Wales has made all of the right choices in the last 20 years and reached perfect answers to the challenges that we face. As all of us who work in health and care know, there is rarely such a thing as a perfect answer. In fact, in the time I've been a minister, I don't think I've ever managed to make a perfect decision, because there are rarely perfect choices to make in life, let alone in government. Indeed, there are times where there just aren't right or wrong answers, just different answers to make. And we, of course, have made different choices, and some of those do lead to different outcomes. And some of the things we've learned in Wales by taking a different path are worth sharing, hopefully deeper understandings of other systems, and the potential to be adapted or adopted more widely. I'm going to go on to two main themes of our constructive differences and choices in greater depth. But I do want to share some reflection on travelling here today and going across Offa's Dyke, the ancient border between Wales and England. For many people in the room, there may be an understanding of health and social care in Wales that is influenced by media coverage and perhaps by reporting of the political debate around NHS Wales. Because, as all of us know, NHS Wales is often subjected in Westminster and by media surrogates to inaccurate and unfair criticism. One of the more obvious examples was a previous Prime Minister describing Offa's Dyke as the new line between life and death. Now that, I think, was an occasion where the acceptable rough and tumble of political arguments and debate crossed the line into something much more unpleasant and, frankly, willfully dishonest. And I say that not as a politician of a different persuasion to the person who made the comment, but as someone who, through the day-to-day work that I do, see the extraordinary levels of compassionate and effective care delivered by people right across NHS Wales. And working with people whose outstanding professionalism saves lives every single day is one of the great privileges of the job that I do. And we see that again, both in emergency services with the awful events yesterday, in the previous terrorism attacks. These are people who really do go above and beyond the simple job description. To sully their work and their reputation in Wales was quite breathtaking, and it had a very real impact upon our staff. But I also make a defence of NHS Wales and our health and social care system based on facts, because the latest data reveals why there's a growing appreciation that NHS Wales is making progress across a number of areas. Our performance on ambulance waiting times leads the UK. The British Heart Foundation recently described our cardiac rehabilitation service as a world leader. The number of people experiencing delayed transfers of care from hospital remains close to record lows. We think that is at least in part down to the relative protection of social care budgets, but also the way in which we work and deliver our system in partnership. The number of people waiting 8 weeks for diagnostic tests is at its lowest for 6 years, and the end of March saw the best performance against 26 and 36-week figures for the last 3 years. And our performance against urgent suspected cancer target is the best since November 2014. And as in the cases we've seen earlier from Simon Stevens and others, with the rest of the UK, we retain a very strong patient satisfaction from the actual experience of healthcare. And just a brief word on mental health that I know has been mentioned at this conference and previously before. We already have waiting time standards in Wales that people are looking at and talking about in England. And we changed those waiting time standards to a more stringent 28-day measure. And we haven't simply talked about the need to invest more in mental health. In progressive and successive budgets, we have actually invested more in the service and not simply leaked that money into the bottom line. And on CAMS, again, a subject of much discussion across the UK, we again changed our target to a 28-day waiting target, and that standard has been met across Wales in our most recent figures from March this year, and we reduced the number of people waiting by 77% in the last year. That's not pretending things are perfect, but real and significant progress that is being made. Just as in the rest of the UK, the context for these improvements are robustly measured and monitored by Statistics for Wales. But the demand for NHS services is increasing across every single area of activity. And the drive to improve performance has been achieved in part through increasing our accountability focus within NHS Wales. It's a system supported by a 3-year integrated planning approach, by use of escalation frameworks where needed, and also clear oversight mechanisms. Now, having felt obliged to correct some of the misrepresentations of health and care in Wales, I feel I should point out that I think I need to do that, not least because why, after all, should you attach any importance to observations from another system if you really do think that system is failing? I think combative fact-free rhetoric about good and bad systems doesn't help us in the important business of improving public services. Because across the UK, it's a simple truth that we face broadly the same challenges in health and care. Every health and social care system has areas of excellence and areas for improvement. Indeed, last year's OECD comparison of the health service in the 4 UK nations found them broadly equivalent in terms of quality and performance, and they suggested that the systems went further. And after that review, the more detailed analysis they recommended on 13 different healthcare quality indicators. That was undertaken by official statisticians, and that joint analysis showed that Wales, in a range of those areas, in 13 different measures, were at or near the UK average in 8 areas. We're behind the UK average, so worse than in 1 of those 13 areas, but in the other 4, we're ahead of the UK average on the point about quality and what the use that our treatment actually does for individual patients. So we have a strong story to tell. We also see stroke mortality rates and ASPA hospital admissions reducing. That's particularly encouraging for Wales. I want to come back to the first point of how we capitalise on increasingly different ways that health and care will be provided in the UK, again with a dynamic process of devolution. That greater diversity in health and care policy and practice is something that could benefit all of us, because it comes with it the potential to learn across systems that are experimenting with different approaches. It should allow for accelerated learning if we all keep an inquiring and appreciative mind about what others are doing. The temptation, though, of course, is to turn inwards. Armed with new responsibilities and powers, people can be forgiven for focusing entirely on their own patch. But we need to recognise, this comes for politicians too, that no one has a monopoly on wisdom. Each place can, indeed must, learn from another. And that principle should apply within as well as across service delivery systems. So it's vital that it does if we are to maintain the principle of an NHS that is free at the point of use, as Bevan envisaged all those years ago. Some innovative practice gains traction locally because it delivers better results, and where it does, I think public service leaders have a duty to scale up. And in Wales, we're developing better mechanisms to identify, evaluate, and then expand on good practice. There's a regular challenge I give to the service in Wales to understand what we do, to understand why it works and how it works, understand what improvement looks like, and then to do so with pace and with scale across our system. Part of the challenge, though, is that that can be deeply countercultural, because as we know, people are often resistant to change, and that goes for healthcare professionals just as much as anyone else. Overcoming that resistance to change requires leaders of public service organisations to be brave, far-sighted and humble. Not always qualities that are associated with leaders, but also when I talk about leadership, there's got to be leadership through a whole service, not just people on an executive board, but actually throughout that whole system. We need to encourage and nurture those behaviours at all levels, both within our own organisations, but across the wider public service. Otherwise, we simply won't take the public with us. Now, the Welsh Government has set out our desire to see that approach instilled right across the public sector. We introduced new legislation, the Wellbeing of Future Generation Act, and that places a duty on public bodies to work together to achieve countrywide goals. And one of our 5 national goals is to create a healthier Wales. So each public body has a statutory duty to work towards that goal and to explain what it will do to achieve that end and how it will work with others to achieve that end. There is, of course, a reciprocal duty for health organisations to work with a wide range of public and third sector partners to deliver better outcomes across the span of our devolved responsibilities. And partnership working really should be easier in the context of a small nation of 3 million people. And one of the prizes of devolution that we need to make better focus of, not just in theory but in practice, is how we not just build and create that intimate set of relationships, but then we have a national sense of mission and achievement to deliver that change and reform. Because, for example, I get to have a close working relationship with the chairs of each of our 7 health boards and 3 NHS trusts. We all fit neatly into a room together, and we'll do so again on Monday. But there's also the challenge of how we actually have a system that is close to people on the front line as well, and that is part of what we do regularly. For example, I recently went and spoke in the course of a couple of weeks to over 100 different paramedics in 5 different locations around Wales, able to answer questions, meet them, talk to them, and understand without cameras there, so they could ask any questions that they wanted. Now, that sort of conversation, that engagement, is part of what we want to do to create a different culture. And it goes into primary care as well, not just because of our desire to shift care into the community, but the way in which we engage primary care professionals themselves and help to design and deliver a system and feel real ownership in it. We know that 90% of patient contact takes place in primary care. We know that our aim, as in most governments across the world, not just within the United Kingdom, is to shift resource and activity towards multidisciplinary primary and community care teams, working closely with social care to meet people's needs closer to home, and that is very definitely our explicit aspiration in Wales. It's that common desire to see primary care not simply as the workhorse, but as the driving force for our National Health Service. And we're trying to deliver that with a National Care Plan, but also primary care clusters that bring together not just GPs from different practices, because they don't always talk to each other, but also to see those other healthcare professionals, pharmacists, therapists, and people from social care as part of a system that plans together and takes responsibility together for the health of a wider local population. We know that change isn't easy, and with clusters themselves, not every GP was a willing agent for change, it is fair to say. They asked quite reasonably, is there real value in me going to a different set of meetings that is going to take me away from frontline patient care? Isn't this the government trying to make me fill out more forms to get paid? Whereas now, actually, despite the fact there are still antibodies within the system, and I wouldn't pretend otherwise, there's a much better feeling about the value that clusters deliver and the change that people are themselves seeing and witnessing on the ground. And we also have a parliamentary review to help shape the future of health and social care in Wales, which I expect to deliver practical recommendations to implement in the medium term and then for the next 5 to 10 years. And that will report before the end of this calendar year, but an interim report in July this year too as well. So there's much change and progress to be made. And against the backdrop of our future generations legislation, it was only introduced in 2016, so it's still early days, but it's part of our desire to change the culture and what we expect from each other. The United Nations, in respect of our legislation, has remarked, what Wales is doing today, the world will do tomorrow, and I certainly hope that is true. But that takes me into my second theme of the different choices that we've made in Wales about health and social care. So we've placed fair funding for the NHS in Wales at the top of our list of priorities in government. Inevitably, that means we have to make incredibly difficult choices across the whole range of our responsibilities as a devolved national government to maintain that commitment. I've been very clear with senior NHS leaders in Wales that I expect that investment to be used to transform services for the benefit of our population and to support our policy aims of treating more people closer to home. So since the May 2016 election for the Assembly in Wales, the Welsh Cabinet is committed to investing more than £500 million in NHS Wales. That's, if you like, an additional £169 for every citizen in Wales. We spend 1% more on health per head of population than in England, and critically, we recognise the importance of an integrated system by spending 6% more than England on health and social care combined. But the investment we've made in the NHS in the current year equates to a 4% increase, which will about 2% in real terms. But that money comes with an expectation of reform and improvement, and not simply business as we know it now, because that isn't good for the service or the people that we serve. And I remind the health service it comes at a really high price to other parts of our public services. Now, the modern foundation for the NHS in Wales was established in 2009 when we legislated for a new structure of integrated health boards, and we removed completely the purchaser-provider split. Health boards are integrated in the sense that each board plans and provides a whole range of health services in their region, from prevention through to primary care and into hospital and specialised services. And our health boards are substantial organisations, with 4 of those boards having budgets of well over £1 billion, and our largest health board employing 16,000 staff. Those local health boards, though, work within a national context, cooperating on service-level planning, which requires a wider geographic scope. And using our planned approach to health and care services, we work hard to find the most appropriate level of control and accountability. That integrated planned approach is a choice we have made in Wales, and I think it offers more scope for service change and a shift to prevention, in particular through strong and distinctive primary care. And in particular, we're encouraging that shift to local and community settings with a real emphasis on prevention and co-production using our prudent healthcare approach. And prudent healthcare approach is about the way in which we expect to change and improve the way health services are provided in Wales. It's not about saving money. It consists of 4 principles: that the public and professionals should be equal partners, with co-production being a reality. We want greater equity in our system, so we care for those with the greatest need first. To do only what is needed and to do no harm, and to reduce inappropriate variation through evidence-based approaches. We want to enable patients to be genuinely equal partners in their own health and care, and to be better informed about maintaining their own well-being. So in terms of supporting people, our new Public Health Act brings together a range of practical actions for improving and protecting health, and it focuses on shaping social conditions that are conducive to good health and where avoidable harms can be prevented. So we've created licensing systems for special procedures like acupuncture, body piercing, electrolysis, tattooing, and it prohibits intimate piercing for under 16. So a range of preventative and protective measures, but it also allows us to finally take a much sounder, needs-based approach for community pharmacy provision. And on community pharmacy, we've made a different choice on funding. We're also investing in an IT system to give access to a summary GP record across our network. We expect to see more services shift into community pharmacy, and in return, we expect to see a greater emphasis on quality and not simply payment by volume. There is an urgency about our desire for reform and service change, because the challenges of rising demand for health services in Wales are no less than here in England. Indeed, Wales has the highest proportion of older people in its population of all the UK countries. A legacy of our post-industrial economy is we have significant pockets of deprivation, but we've succeeded in increasing vaccination rates, and indeed we announced today that teenage pregnancies have halved over the last decade. So reducing health inequalities remains at the heart of our agenda. We do, though, know that we can't simply spend our way out of the challenges of an ageing society. So we believe a community-based model of health and care is best suited to responding to that future demand. That's why we maintain investment in social care despite continuing austerity. That does require tough decisions in our areas of responsibility and rigorous prioritisation. But there is, though, a limit on what we can do if the UK government continues to make cuts to public service budgets. And some wider honesty on this from Whitehall would be refreshing and helpful. I genuinely think we need to see a different approach, or we will see unacceptable outcomes in health and care right across the UK. We have, though, introduced what we regard as groundbreaking legislation in our new Social Services and Wellbeing Act, which means people will have much more of a say in the care and support that they receive. As well as reshaping services, we're continuing to push for better day-to-day performance. So in recent months, Wales is the only UK nation to show improvement in the time it takes to get to those critical 999 calls, and that followed my decision to implement a new clinical response model to prioritise life-threatening cases during a trial period. It's fair to say that decision at the time wasn't welcomed by people in all political parties, but now there's a recognition that it's worked. That's why we've now implemented it following an independent evaluation as standard business on a permanent basis for the ambulance service in Wales. And I'd like to see key things we measure focus increasingly on outcomes and not simply on process and activity in terms of time and volume. Because traditional measures and targets don't show us the full picture, and in many cases are probably not things that really matter to patients. But if we don't measure and report on anything else, they'll be the only markers of care and quality that we have. That's why in Wales, we're actively exploring a more intelligent set of outcome measures in eye care and in cancer care. And I look forward to having recommendations for either piloting or implementation within this calendar year. Now, change in this area requires a mature political debate. But where we can point to improved services on the back of our earlier work, we have a sound basis to move forward and generally introducing more outcome-based measures within our service to build a generally strong evidence-based case. And in Wales, we also choose to invest in those people who want to make a commitment to our NHS. Last March, Wales became the first country to introduce legislation around nurse staffing levels. And the new law requires health boards to ensure sufficient nurse staffing levels are maintained, and that's calculated using the professional judgment of the nurse in charge of the shift, and a workforce tool to ensure the acuity of patients is considered, and in a way that takes account of recommended staff ratios. And again, Scotland is looking at what we are doing. To secure the workforce we need, I believe it's important that increased investment in training and development is combined with an opportunity to work in Wales, and then an expectation also that those who particularly benefit make a commitment to Wales. So NHS bursaries for eligible nurses, midwives and allied health professionals will continue to be made available in Wales this year and next year. And similarly, our efforts to build a workforce for the future led recently to a 21% increase in the number of junior doctors choosing to come or to stay in Wales to train to be a GP, with over 91% of our training places filled to date this year. And I think it is our constructive approach to workplace relations that means that we haven't seen a junior doctor strike, as has been experienced in this part of the country. But that is, again, a choice, and it requires us to work at those relationships and not simply assume they will be there tomorrow. I am, though, generally worried about recent figures on nursing and midwifery registrations from EU countries, which show a dramatic decline in England following last year's referendum. And that does show how an approach in one part of the UK can have a significant impact on the NHS as a whole across the 4 nations. I also think on recruitment it's frustrating and nonsensical for the Home Office to insist on an approach to immigration that prevents us from recruiting skilled professionals into our NHS in the numbers that we need. Combine that with the recent UK government insistence on pressing ahead with charging the National Health Service for every person who comes support and work in our service, and you get a picture of a UK where recruitment is an incredibly challenging picture, and more so than it needs to be. And the BMA estimated that's a £3.5 million figure in England, and that money will come out of frontline services to go back to the Treasury. And it's the kind of revolving door policy that penalises unnecessarily and delivers nothing of value, in my view. So I'd ask the UK government to think again, because we must do more together to ensure that we can recruit and retain a stable and well-trained workforce, because the future of our NHS right across the United Kingdom depends on it. In terms of UK-level profile, perhaps some people will be aware of the eye-catching measure we took to change the way in which we deal with organ and tissue donation with an opt-out system. So people in Wales are now deemed to have no objection to being a donor unless they've registered to the contrary. And in the first year of the legislation being in place, 160 organs were transplanted in Wales and 39 through the deemed consent route. We were the first EU country to do so in the UK, but Scotland is now looking to follow our lead. And in Wales, I think we've been working on that progressive agenda within health and social care for some time. I hope there are points of interest and learning from our experience on the different choices that we've made, but I do still see more opportunities to be seized within our system. In particular, I work with Cabinet colleagues in Wales to develop the contribution of the NHS and social care to other government priorities, in particular economic growth and prosperity. There's a closer working to still be gained with industry and university partners to drive applied research and innovation, to support new product development and business growth, and to increase high-value employment in Wales without at all compromising the values and ethos of our service. Health, life sciences and social care are key industry sectors in Wales, just as across the UK. An example of this approach is designating a number of our health boards with a university status, and that helps to bring partnership and innovation to the heart of our integrated services, and I want this to be an even more powerful driver of change to improve efficiency and effectiveness of health and care services, and at the same time to create economic opportunity. We know that people's health and well-being outcomes are determined mainly by factors outside of traditional healthcare settings. So we need to think hard about how our services contribute to improving the broader social and economic environment, and then, of course, find a way to achieve more. At a UK level, we recognise there are also big socioeconomic differences. London and the South East are not the same as the North East and the North West of England. So if we think of health services being part of a broader health economy, we need to think and recognise that a one-size-fits-all approach is not necessarily going to be the best answer. So we believe devolution has allowed us in Wales to make more appropriate choices for our own needs. And increasingly, we will explore how health services can be configured to create added value as part of that regional health economy. And I'm generally keen to work with colleagues across the UK and beyond to learn from each other. As well as learning from each other within England, I hope there are things we can learn from Wales. But one of the great privileges of this job is to get to see how that learning takes place in a workplace setting, to understand what people are doing, the commitment that is made day to day, and actually to serve those people in a role in government, and to recognise that working together, we can deliver a better service both for our staff to work in and for our public to take part in and receive.
Vaughan, thank you very much for that. I think you'll agree you got a slightly different perspective on Welsh healthcare from Vaughan from what you might get if you are a diligent observer of Prime Minister's questions in the UK House of Commons. Thank you very much for that. And in particular, I may say personally, as somebody who's written a large number of parliamentary reports advocating more joined-up health and social care, and who's also advocated a cross-party review of the future funding and structure of the health and care system, I'm interested in your experiences of both of those in Wales. Having announced a format, I'm now going to slightly change it, if that's okay, because Bruce Keogh needs to catch an early train in order to get himself back to London, given the circumstances. So what I'm going to do is to continue the theme of localism and to ask Linda Thomas, who's Vice Chair of the Local Government Association's Community and Wellbeing Board, and Louise Park, the Associate Director of Ipsos Mori, to come and join us one discussion about localism so that we can bring Bruce Keogh onto the platform. So please welcome Linda Thomas and Louise Park. Welcome. So, we've heard the view from Wales. I was going to go first to you, Linda, from the local government perspective. Clearly, the English Local Government Association has many of the same ambitions for place within different parts of England that Vaughan's been articulating in Wales. And I'd be interested in your perspective on the things that he's been saying.
Right, well, Local Government Association is built on consensus, so this is about what the whole of local government feels. It's not a party political broadcast. We've been very consistent and long-standing champions of local place-based leadership, and therefore we've been at the forefront of calling for local freedom and flexibility because we want to find innovative ways of pursuing our local ambitions. I know time is pressing, so I'll just do some salient points. The first thing that you have to have is shared leadership. It's absolutely vital. There can't be one sector imposing its culture and priorities on the other. And that needs to be acknowledged immediately that you embark on this, and you have to build up trust straight away. There has to be a shared vision, a narrative on how devolution will help you. One thing I would say is effective devolution is evolution, not revolution. I think that's important to bear in mind. And in Greater Manchester, we've built on the 10 locality plans. So it's a bottom-up approach rather than a top-down approach. And you definitely need shared systems. For data and intelligence, you need to assess needs, you need to deploy resources to where they have the greatest impact, and you also need shared performance management in order to track wherever possible. I know we've had some difficulties with STPs. I know Greater Manchester's in a slightly different position. We've got £6 billion, we've got £450 million transformation fund. But can't stress on you enough the importance of the wider determinants of health which local government bring to the table. Our driving force in Greater Manchester is about the well-being of people, getting them into jobs and employment. Things also like housing, all the things that local councils can bring to the table. So we need to be there at the start of the planning decisions, You can't just bring us in as an afterthought once you've actually made the decisions. And I think this might be where we're slightly coming unstuck in STPs at the moment, but I'm sure that everybody, because there is such willingness, can find a way through. In Greater Manchester, we're already at the stage where we're now looking at each 10 local authorities moving to a local care organisation. So we're going to have joint commissioning, we're going to oversee performance, and generally joint responsibility for health outcomes. And the point about all this is we can bring strengths to the table. So we need clinical, we need preventative, we need accountability and communication, which will bring the public on board. And we see this as a strength coming together rather than a hindrance. And we think this is the only way our health system can survive.
Thank you very much for that. Vaughan, I'm going to go to Louise in a moment, but this must be very familiar territory to you, that in order to engage in change with local communities, it can't be something done to them, it has to be done with them, engaging them in the process.
No, absolutely. We've seen difficulties in trying to deliver change where people haven't been brought along. You need clinicians to come with you, but you have to take the public with you as well. And the point that's been regularly made, you need the trust of clinicians to help you to engage the public. But it needs to be an active and an honest conversation. And in Wales, in the legislation I mentioned, the Social Services and Wellbeing Act, we've directed people to work in partnership with local authorities and health boards together to undertake a needs assessment together, and then to do something about it together as well. Otherwise, the conversation isn't ever going to be joined up. And there's a challenge of how much you do by encouraging and how much you do by directing people to work together as well. Now, that's something how you do enough to create the culture where it then takes place as a normal way of working, but it's just as much of a challenge on our side of the border as well. But I think we're probably a few steps ahead, but we'll still want to learn what's happening in England where it's been successful as well.
Thank you. Ipsos Mori brings a different perspective to this question, because you've actually done some work, Louise, I believe, in analysing how the public actually experiences these aspirations, whether expressed by the Welsh Government or the local leadership of different health and care systems. You've got some evidence about what people actually think about this?
We certainly do. The way the public feel towards the localism agenda, devolution, is that there's sort of broad support for it in terms of the theory or the concept behind it of, you know, transfer of power centrally towards local areas. But there's sort of three things I'd say about that. One is around awareness levels amongst the general public, and of course I'm talking at a very overarching level here, and it holds the public is not one mass. But awareness levels are pretty poor. So actually we've got about 3/4 of the English population who don't know, have never heard the term devolution, or say they'll know very little about it when you describe what that may actually involve. So there's something around awareness. There's also something around there not being universal support for the concept of devolution depending on certain policy areas. And health and social care is really interesting in that respect, because it's an area where the public are not as convinced that local decision making makes as much sense as it might do for subject matters like transport or housing. Those sort of issues being, you could call them really hyper-local issues, that they're the things that affect people on a day-to-day basis, that they're visible, they're tangible. And actually, when you look at health and social care, you've got about 44% of the population saying those decisions should be made nationally versus 38% saying locally. And when you compare that to housing, it's 17% and 65%. So it really does show you that health and social care is slightly different. It's seen in a different way. And the third part really is understanding what might drive, fear probably is too strong a word, but some resistance towards the idea of localism is this concept of, or fear about a postcode lottery. And that really, on one hand, the public are broadly supportive of this idea of local decisions, but that doesn't sit well with the idea and the desire to have equal access to services.
Thank you very much. You will have noticed earlier in the session that even in this digital age, there is no replacement for the note brought onto the stage in order to communicate the fact there needs to be a change of plan. With apologies for it being very short, I'm going to cut it short at that moment in order to invite Bruce Keogh to come and give his address. So thank you very much, and I'm sorry that we've had to cut it short. Okay. Thank you very much. Please thank you. Right. Ladies and gentlemen, we are now in what is genuinely the final session of this conference. I speak as a West Midlander when I say the really important announcement that Bruce Keogh made in April was not that he was stepping down as the National Medical Director of NHS England, but that he has been appointed as the incoming chair of the Birmingham Women and Children's Hospital. So please welcome somebody who needs absolutely no introduction, Sir Bruce Keogh, the National Medical Director of NHS England.
Good afternoon, ladies and gentlemen, and Chairman, thank you very much for the invitation to address the Confed. I have to say we've got the real diehards here this afternoon. You're obviously the people with energy and stamina in whom we can place the future of the NHS, so thank you for staying. It seems to me that however we look at it, that healthcare is quite simply a people's business. And at its simplest, you can boil that down to two people in a room. One person who's sick, frightened, in pain, seeking help, and another person who is there to try and help them. And everything we do, whether it's the structures of the NHS, the real estate in which we work, the IT constructs which help us, or the HR processes in our organizations, should be there simply to ensure that that person seeking help gets effective care, safe care, and compassionate treatment. And by necessity, healthcare changes, science advances, society changes, technology changes, and there are always on the horizon better ways of doing things. So we have to change all the time. Sometimes that change can be quite significant and disruptive, but the vast majority of the time it is simply small changes, marginal gains that we see, incremental change. And one of the things that struck me over the last 10 years is that people don't generally fear the concept of change. What they really fear is what they might lose. And I'll come back to that, but I think there's cause for optimism as we look at many of the challenges which are facing us at the moment. But in order to face those challenges, I want to build in you confidence that we have the ability collectively to deal with those problems. So I want you simply to sit back, because it's the end of the conference, relax, and just imagine that you lived in a country that had made a major contribution to world medicine, that had discovered that the mosquito was the carrier of malaria, that had postulated the theory of evolution, that had unraveled the double helix, that had discovered and invented the smallpox vaccine, which is said to have saved more lives than have been lost by all the wars that humankind has ever fought, that discovered antibiotics, that cloned the first mammal in Dolly the sheep, that invented in vitro fertilization in a district general hospital, which has changed the lives of countless families around the world, that did the first blood transplant, the first stem cell transplant, that developed the ability to stop and start the heart electively, which is the basis of modern heart surgery, which is my specialty. Or if you were to imagine that that country had made a pretty modest contribution to medical technology. It invented the clinical thermometer, the intraocular lens, the ECG, the artificial hip, the laryngeal mask, which is used around the world in anesthesia, invented the MRI scanner and the CT scanner. You might be forgiven for thinking that actually that was quite a good country to live in. And then if you imagined that that country also had 4 of the top 10 universities, that had 1% of the world's population, invested 3% of the world's investment in medical research, that produce 6% of the world's medical research papers and 16% of the highest cited medical research papers. You'd think that's pretty good. And then you might reflect on the fact that that same country had twice as many Nobel Prize winners for medicine or physiology per capita of population than the United States. And then imagine if that country also had a history of innovation, genuine innovation, such that it always ranked number 3 or number 2 in the Global Innovation Index compiled by INSEAD and the World Intellectual Property Organization. You would think there's something going for that country. But imagine also if it had the biggest semi-integrated healthcare system in the world. And then imagine if you could link all of those things together. I put it to you that we could have the best, most efficient, most effective healthcare system on the planet. Now, at the time that the NHS was founded in 1948, the political deliberations and the social change that was going on in 1947 were quite tumultuous. Not only had there been a terrible winter, but there were the worst floods for 53 years. There was a problem with the exchange rate with the dollar, something that you might be familiar with at the moment. And all of that pushed up the cost of foodstuffs, so that our country ended up with rationing that was worse than during the war. So my hypothesis to you is that really good things can be born out of quite significant hardship. Now, our NHS is a big system. It sees deals with over 1 million patients every 24 hours, if you add up the figures, processes 1 billion prescriptions a year. And through the spine, we process 4 times as many transactions per second as all credit and debit card transactions go through are processed in our industries at any time. But all healthcare systems around the world are gripped in a quadruple pincer of rising demand, rapidly increasing costs, changing public, political, and professional expectations, all within a constrained environment. Now, that might not be immediately apparent, but the United States can't continue to function as it does on the amount of money it has. Germany can't, Poland can't, Zimbabwe can't. We sit somewhere in the middle of that. And what is also clear is that the amount of money that was a point made by Jeremy Hunt earlier was that the amount of money that's available for our health service, given that it's a tax-funded system, is intimately related to how well our economy does. Now, we have another issue in that we have, at the moment, more older people than younger people in our country. And that creates a bit of a paradox for us in the sense that older patients require continuity of care, they require sometimes more complex care, and they like it close to home. Meantime, we have a younger generation who expect immediacy of access to information, and they don't want to sit in waiting rooms looking at Sunday Times magazines that are 3 months out of date. So we have to deal with both of those on parallel tracks, recognizing that it won't be long before the younger generation or the older generation. And when I look, and anybody that knows me, I'm not anything resembling an economist, but when I think about companies that have gone through difficult financial times, it seems to me that they do 3 things. The first is that they take control of their finances and understand those forensically. The second is that they ask their customers what they want. And the third is that they innovate according to what their customers tell them. And I'd like you just to sit back for a second and reflect how well our National Health Service has asked people what they want and innovated according to what they hear. You know, I don't think we do that well. And of course, the thing that happens in other sectors is they have to respond with urgency. And we have urgency being forced on us. We don't respond with the degree of urgency that we sometimes have to for a whole variety of reasons. One other observation I'd like to make is that people outside the NHS can commentate on the NHS. People outside organizations can make commentary, but only people in those organizations or in that system can actually change it. And that leads me to the firm belief that the intellectual capital for solving the challenges and the problems that the NHS faces at the moment lies in the 1.2, 1.3 million people who work in the NHS. And we need to free up that intellectual capital to give it the momentum that it deserves in order to help us make the sorts of changes that have been discussed at this conference. And that makes me want to make 2 points. The first is that in the face of relentless pressure that everybody working in the service is feeling at the moment, there is a risk that we drift into a focus on risk aversion and blame. And I would invite people to genuinely ask, I'd invite politicians, the arm's length bodies of which I am part, the regulators, what it is that results in the terrible statistic that the life expectancy of a chief executive in our NHS in the acute sector is only 2.5 years. And I would ask people to reflect on whether that is really a fair reflection of the capability of those individuals, or is really a reflection of the inadequate support that they receive. I know where I cast my vote. Good leadership is supportive, empowering, and values-driven. It is not frightening and suppressive. And I think we all need to pledge that we will focus on ensuring that we provide supportive, empowering, values-driven leadership. Because if we don't, we've seen on occasion in our health service where that leads. The second point I'd like to make relates particularly to junior doctor colleagues. I believe that they are our most powerful agents for change. They have a vested interest in the future, they're values-driven, they work very hard, and they move from hospital to hospital in the same way that our young nurses move from ward to ward. Between them, they can be the biggest agents for change because they see where good things are. They see where the safety issues lurk. We need to listen to them. We need to make them feel that they are part of the future. And I would really implore organizations to engage our young clinicians in helping build the future for our NHS. Now, if we're going to tackle really difficult problems, we need to understand that between us, we can solve some very difficult issues. I remember when I was a surgeon in Birmingham, something came into the office which said that an irritated Secretary of State with a history degree had decreed that we needed to reduce the rate of MRSA by 50%. I looked at it, I thought, what are those guys smoking? And said I remember saying to my secretary, all they need to do is go down to the ITU and they'll see, as a cardiac surgeon, they can see old patients who have had heart surgery, they see lung transplants, heart transplants, immunosuppressed patients. This is the price we pay for the technological advances we're making. Well, I'm glad to say I was utterly wrong. Because in 2003-04, there were 7,700 cases of bloodborne MRSA. By 2015-16, I think, it was down to 819, a 90% reduction. And you know what? We knew what to do all along. We knew what to do from the time of Semmelweis in the mid-1900s. But it took a politician to inject that sense of ambition into our health service. We should have done it. The second area that I'd like to say we've made massive progress on is trauma. Some years ago, it was clear that we weren't getting the results for trauma that we should, and there was great variation around the country. So with encouragement, I have to say, from the Public Accounts Committee, we introduced 27 trauma centers, major trauma centers, nested in 22 networks. And it was clear that some ambulances would have to drive past not one, but sometimes two regular A&Es. Some of the commentators outside the NHS said, this is a nightmare. This is scandalous, it's money-saving, and patients will die in the back of ambulances. They were utterly wrong, because in the first year of operation, those patients with the most serious injuries, their odds ratio of survival went up by 15%. In the second year of operation, the odds ratio of survival went up by 30%. In the third year of operation, the odds ratio of survival went up 50%. And what's more, the variation as measured on risk-adjusted mortality for major trauma was reduced. Those networks have recently been tested, particularly by 3 terrorist attacks and the frightful events which have emerged over the last 24 hours. 121 patients following Westminster Bridge, Manchester, and London Bridge attacks were admitted to hospital. A third of them into critical care in a very serious condition. I'm glad to say that of those that were actually admitted into hospital, there were no deaths. And what's more, people survived injuries that had previously regarded as unsurvivable. In Manchester alone, those patients underwent in the first few days 400 hours of surgery, over 400 hours of surgery. This is our NHS at its best when we need it the most. We had similar discussions around stroke, because in London, there were 32 hospitals that were admitting patients for stroke. There was scientific evidence emerging that if you gave clot-busting drugs, you could improve things. So the number of admitting hospitals were reduced to 8. Again, people said, this is cost-saving, people are going to die in the ambulances, it's a scandal. Well, once again, that was wrong. We have ended up with a reduced mortality rate, which I'll come to in a moment, a shorter length of stay, in that 40% of people go home within 3 days, and more people returning to independent living. So the trials are beginning to show that for every 100 patients who are admitted, all of them benefit, and that we are likely to have 6 more people returning to independent living and 3 fewer deaths. Similarly, we've been able to tackle hip fractures, a very common condition in an elderly population. We introduced a best practice tariff, which said that to get full payment, you needed to do 10 things. Now, broadly, the 2 most important things were a quick operation within 36 hours, and secondly, that patients should be looked after by a geriatrician as well as an orthopedic surgeon. Now, 90% of people now receive at least 9 of those processes. And between 2010 and 2014, the length of stay for hip replacement following fracture was reduced by 6 days, saving 354,000 bed days for the NHS. A tremendous advance. In myocardial infarction, for the most serious heart attacks, 99% of our population now get their coronary arteries opened, which is absolutely fantastic compared with many other countries. 77% of patients are treated within 150 minutes of picking up the call, and the median time from the moment you arrive at the front door of the hospital to having your coronary artery opened is 41 minutes, which compared with many other institutions around the world, let alone countries, is a fantastic result. 98% of the patients are discharged on antiplatelet agents, 96% on beta blockers, 94% on ACE inhibitors, and 97% on statins. I would challenge you to find another country with clinical practice that good. In dementia, we've reduced the antipsychotic treatment by 50%, which has had huge benefits. And we've increased the diagnosis rate from 40% to nearly 70%. Now, there was some reticence about that because people said there is no medical treatment for dementia. But the advantage of having a formal diagnosis of dementia is that you can have post-diagnostic support put in place, and that has transformed the lives of many families around the country. In 2009, it became clear that we had a lot of avoidable deaths in our hospitals from venous thromboembolism. And alignment between parliamentarians, the Royal Colleges, the NHS Management Board, and others, we were able to increase the rate of risk assessment for venous thromboembolism from about 40% to 90% in under a year. One of the fastest clinical change programs the National Health Service has seen. And evidence over the last 2 years has begun to suggest that we have had a significant impact on reducing the problems associated with venous thromboembolism. As Stephen Dorrell has said, I will be moving on from this current post, but by the time I leave at the end of the year, I'm absolutely clear that I want a similar focused approach on sepsis. Now, our health service is also going to be subject to a number of other external variables, which we need to be alert to because they're going to change the way that medical practice is delivered. The first is mobile technology. We live our retail lives, our financial lives, our social lives, our travel lives online. Health will come very soon. The mobile technology will become the pluripotent stem cell of healthcare regeneration. It will turn healthcare into a knowledge transfer business in a way not dissimilar to the travel industry, and it will come fast. Artificial intelligence will start to increase our diagnostic capacity. The people at Google have told me that we're within 4 years of machine reading of some routine X-rays. And similarly, it'll transform histopathology. So we need to think of the implications of that for efficiency and the implications of that sort of technology on our workforce. And the third technology, which is going to have a big impact, is genomics. You know, initially, it took 10 years and cost $2 billion to decode the human genome. It now takes less than 24 hours and is around the 300-pound mark at its very best, depending on the granularity that you want to do it. But this makes that kind of knowledge, it brings it close, very close to mainstream medical practice. And we're in the process of looking at NHS England, how we turn our NHS into the first healthcare system in the world to utilize genomics on a routine basis. But it will allow us to predict those people most at risk of certain diseases. It will allow us to focus treatments on those diseases in a much more focused way than we could do before. But it will raise some very significant issues about the cost of drugs as they become more and more focused. There are also general purpose technologies which are being developed in other industries which will have an impact. And there's a long list of those, but the one that sticks in my mind, and I don't know how true it is, but it comes from a very reliable source, that changes in superconducting technology mean that there's the possibility of handheld MRI scanners within a decade. So these sorts of things will come upon us, and we need to be alert. And in the context of all the things that I've alluded to, I see an elderly population who live on a physiological spectrum. You just need to go into any GP practice or any clinic, and you'll see octogenarians who are sprightly, walking their dogs, riding their bikes, and the other end of the spectrum, people who require quite intensive medical therapy. But most people will be somewhere in the middle, a few tablets, a bit of support. But that spectrum is a continuum. And it's very different to the spectrum of people that we were treating at the inception of the NHS. So I find myself saying, which is probably unwise, but what would Bevan do now if he were to come back? Well, I think he would look at our society, he would look at the physiological spectrum of this elderly population, and he would recognize that when the NHS was set up in 1948, the life expectancy of a male was just over 65 years. So broadly speaking, half the population died before retirement age. He would now look at the life expectancy and see that the life expectancy for a male is of the order of 82 years. He would recognize that something's very different. And he would look at the physiological spectrum and he would see that we have created an artificial fracture in that spectrum that is philosophical, bureaucratic, administrative, and financial, in the sense that we have the NHS over here, and we have social services and prevention under the jurisdiction of local authorities over here, on different financial models, different bureaucratic models, and with a set of very practical differences, which mean that it is very difficult for those people delivering services to offer people the kind of joined-up service that they need, and it is very difficult for patients who are trying to navigate those services to get the sorts of treatments that they need. So I think he would be looking for a joined-up health and care system, which is exactly the objective of the STPs, the accountable care systems that Simon Stevens was alluded to earlier, where we get the people with a vested interest in healthcare, social care, and prevention, all in the same room, looking at how they do stuff together, and in time, sharing budgets. That has to be the way forward. We have to find a solution to that artificial fracture between the health service and other services which people increasingly need. And to do that, I think we need to have a very clear understanding of the triangular tension, if you like, between rapidly increasing demand or steadily increasing demand for our health service, the financial constraints in which we have to operate, and the rate of transformation, because some of that transformation will need to be quite disruptive if we're to meet these demands, but most will simply be incremental and marginal. It is clear to me that we all want a values-driven, evidence-based and outcomes-focused NHS. And to do that, we need to focus on the issues that I've just alluded to. But it also seems to me that we're caught in a paradox. Nye Bevan wrote a book called In Place of Fear, which is still available on Amazon. It addresses every single question about the NHS that you hear being asked today. It just does it in 1950s English. But the arguments are very compelling. And he describes the NHS as being set up in place of fear, the sort of fear that people have when they become sick. But in my mind, there is another issue, and that is that after the war, people were frightened of the past. They didn't want to go back there, which meant they were not frightened of the future. The paradox we have now was illustrated in some of the slides that Simon Stevens showed, that our population are pretty content with our National Health Service. We're seeing some of the highest ratings that we've seen over the last 30 years. And when you're content with the present, you're frightened of the future. So it is our responsibility to replace the fear of the future, which is attached to the sorts of changes that we need to make, with convincing arguments for the benefits of that change that mean that people do not fear the loss that ensues. It is our responsibility. We're guardians of the NHS, not just for this generation, but for the next generation. And I come back to the point that in our endeavor to change our health service, we must never lose our focus on the fact that our raison d'etre is to ensure that those two people in a room have a satisfactory, safe, effective, and compassionate encounter. Thanks very much.
I'll let you go in a second. Keith, thank you very much. You said at the beginning of what you had to say that the people sitting here now are hardcore, but you gave us all full rewards. So I just want to say a big thank you to you. I know you have a train to catch. You are, if I may say so, one of those leaders who always makes us feel better. And that, I think, is a note on which I'd like to say thank you to you. Thank you to everyone for attending Confed17. We hope that you've enjoyed the conference. We hope that you've enjoyed, in particular, this final session. And we look forward to seeing everybody Wednesday, 13th of June, 2018, in Manchester. Thank you very much for your attendance.
Thank you. Stephen, thanks so much.
Thank you very much.
Thanks for your kind words.
Stage, River Mersey